Okay, welcome back to the next session today. And just to note, there's an extra about 25 people in the room compared to the first session, so you might need to squeeze in a bit more. But I think with this session, I think we're all increasingly aware that with the accreditation processes going on in multiple hospitals around the country, that there's a lot of extra value that could be added to the quality of patient care by broadening the scope of available cancer research to the wider multidisciplinary team. And so we're lucky to have a good lineup of speakers today. The first speaker, Professor Declan Devane, unfortunately has been affected by the storm in Galway last week, so they're without electricity and probably running water and heating and maybe a roof as well. But thankfully he has pre-recorded a talk for us today, so I think we'll go straight into that now. Thank you very much.
Good afternoon, everyone. Thank you for the opportunity to speak with you here this afternoon, and in particular thanks to Evelyn, Seamus and Claire for making this happen. I'm sorry I can't be with you in person this afternoon, and I'm grateful for the opportunity to be able to record a presentation and hopefully it's playing seamlessly for you right now. So my name is Declan and I am representing the Health Research Board Trials Methodology Research Network. And I want to share some information about the HRB TMRN with you this afternoon. So who are the HRB TMRN? It's a collaborative network across 5 university partners, including the University of Galway, University College Dublin, University College Cork, Trinity College Dublin, and the University of Limerick. But we work with partners across the full HEI landscape nationally and indeed internationally. Why are we here? Well, we're here to strengthen how we plan, do, and share the findings of trials in Ireland through a programme of work which we hope impacts in Ireland and also internationally. And that will mean that trials in which the network are involved are more usable in every sense of the word, better planned, better conducted, better designed, better reported, and more usable. And we hope that trialists who engage with the Health Research Board's Trials Methodology Research Network and use its supports and services will be better equipped to advance the trials methodology agenda because it's important to do so. And I'll touch on some of that as we go through this presentation. Our work built on 4 core pillars of activity. They are support services, research and innovation, public engagement, and training and education. I'm just going to have an opportunity to touch on each of these this afternoon and directly to where more information can be obtained. And collectively across those 4 pillars, we believe that we have evidence and can demonstrate that HRB Trials Methodology Research Network has helped create a culture shift in understanding of trials methodology and how we advance knowledge about how we better plan, conduct, analyse, report, and share the findings of randomised trials. So picking on the first activity, the support services. So one of the key support services we offer is grant application support. And that's focused primarily on to embed primary trials methodology questions or work packages within grant applications. By primary trials methodology questions, we mean questions embedded within your clinical trial application that are asking questions about how we better improve how we plan, do, analyse, report, and otherwise share the findings of randomised trials. So it's about improving the processes from how questions are generated and prioritised for trials all the way through to how trial findings are used to inform policy and practice. They're not focused on how we answer clinical or other health problem or other health service related questions. They're focused on how we improve the primary trials, the methodology within trials. We have supported over 100 applicants to the HRB DIFA scheme, and this replacement will be announced shortly, I understand. And we offer various support levels to meet different people's needs. And that can be from co-applicant status to collaborator, or indeed as supporting infrastructure. And that will depend on the nature of the needs primarily and experience of the applicant team around primary trials, methodology, research, and of course the nature of involvement and expectations there. Critically, we offer partnerships across a large number of international collaborations and have a meaningful footprint with some important collaborative supporting collaborations with a lot of other organizations and initiatives. And there are people on the speaker platform today that I see who are leading some of these organizations and have lead roles within some working groups within these organizations. So one that I would like to highlight in particular is it rolls off the tongue that the MRC NIHR Trials Methodology Research Partnership are abbreviated as the TMRP. It's a UK-based network that brings together a number of networks in the UK, a number of institutions, largely university institutions and other partners working in trials and trials methodology research. It's a large organization. They have a number of working groups which specialize in specific areas relevant to trials methodology. We have Irish partners involved in a number of these working groups, and there's opportunity for Irish partners to become involved at all different levels. Whether somebody is interested in hearing more about these particular areas or has a particular expertise in or would like to become involved in the work within these particular groups. I think these groups have led on some of the methodological developments that feature in how we are guided to plan, do, and share the findings of trials now. Some recent examples of that will be in the outcomes group, where two recent reports in the B&J for reporting guidelines on reporting surrogate outcome measures was conducted within one of these working groups. Lots of opportunity there. So joining a working group, we feel, offers an opportunity to build on the achievements of the broader collective network, while also opening up and exploring new collaborative opportunities and avenues to together try to make continued progress and advance in trials methodology, developing capacity, and further, of course, making trials better and therefore reducing waste. So the Health Research Board Trials Methodology Research Network is a partner network within the TMRP, as our Health Data Research UK, the UK Clinical Research Centre, that Clinical Trial Youth Network, and the UK Trial Managers Network, and the Global Health Network. So you can search for the TMRP online and have a look at those working groups and contact the leads if you wish to join a working group. We would ask that you let us, as the HRB team, know that you've done so, or we're very happy to facilitate introductions also. The next piece of work is around research and innovation, and this takes many different shapes, makes and forms, but members of the HRB team and across our university partners are leading on or collaborating in a number of impactful primary trials, methodology research projects. And here's just a few examples I want to pull out. So, for example, we led on the Priority 1 study, which is prioritizing recruitment in randomized trials. And that led to a top 10 questions of what are the top methodological uncertainties about how we better recruit participants to clinical trials. That led to the Priority 2 study, which was led by colleagues in Aberdeen. And that identified the top 10 uncertainties about how we better retain participants in clinical trials. Other work, for example, has been led by, for example, Valerie Smith in UCD, who led on a training program for training trial recruiters. We also have ongoing work, for example, being led by Professor Peter Doran and Dr. Sinead Holden in UCD, which is building on some of that area of priority work, but it's looking at what are the methodological uncertainties across the trial process, from question prioritization through to trial design, conduct, analysis, reporting, chairing, etc. So what are the uncertainties there? and that work is certainly well past midway and should be and will be an important contribution to prioritising where we put our focus in trials methodology research. If you visit this website, which is priorityresearch.ie, you'll see the current 2 priority pieces of work related to trials methodology. Priority 1, recruitment to trials, and priority 2, retention to trials. The top 10 questions, methodological uncertainties, for both how we better recruit to trials and retain to trials, are available there. And that's just a screenshot from that. Other work we do is we have led and contributed to the development of dozens of core outcome sets. So these are the minimum set of outcomes that should be measured and reported when you're evaluating treatments for particular conditions. And many of you will know in particular areas that the literature is full of substantial heterogeneity in the outcomes that are reported within particular disease areas, let alone across disease areas. And that creates massive problems in terms of synthesizing that evidence. It also generates a lot of waste in terms of, our outcomes being measured that have not been identified through consensus processes as being important to all the stakeholders that matter, including patients and the public. And the answer to that question is a resounding yes. So we do have core outcome set seed funding. Unfortunately, the call for that has just recently closed, but please keep an eye on it. But maybe one message you can take from this talk will be join the newsletter for the Health Research Board Trials Methodology Research Network, where all our activities are shared. We also have SWOT funding, and a SWOT is a study within a trial, and that is a brilliant vehicle for embedding primary trials methodology research within the clinical trial that's being conducted and the clinical question that trial is trying to answer. So what a SWOT is, it's an embedded primary piece of trials methodology research that is asking a question about how we better plan, do, or share the findings of trials. So it could be focused on things like how we better recruit participants, how we better retain participants, how we better analyze data, what outcomes we might choose, how we better report the outcomes, how consent process could be better, etc. There is dozens of questions that usually can be asked and are needed to be asked within each host clinical trial. They're usually very cost effective because they're being embedded within a trial for which funding is being sought already. And if funded, usually the SWOT involves perhaps comparing 2 different types of recruitment methods, for example. The participants have to be recruited anyway, so evaluating different methods of recruiting could inform knowledge about how to better recruit for the subsequent trial, and do so very efficiently and in a cost-effective manner. That call is still open. Closing date is rapidly approaching. It's next week. But the SWOT funding call, €12,500, is available for the partners, the funded partners that I mentioned earlier on within the network. We do a lot of work in public engagement, and just a few examples of that. And lots of our partners across our partner institutions lead out on work within their institutions on public involvement and engagement, and specifically related to trials. 2 ones I'd just like to maybe highlight. One will be the START initiative, which is a competition where we challenge primary school children to plan, design, and conduct their own randomized trial. So these are often 7 to 12-year-olds who are planning, designing their own randomized trial. This culminates in a short list of 3 schools or 3 classes being invited to an award ceremony, and ultimately the winner being announced. So that competition is open at the moment to primary schools. We run an alongside Meet the Scientist webinar, and that's attended by, at the moment, over 80,000 primary school children have attended those Meet the Scientist webinars. Those Meet the Scientist webinars are an opportunity for us to promote and share the START competition. We have had close on 100 randomized trials planned, designed, and reported by children. And trust me when I say to you that they're well able to do it, and they're much more innovative in how they design their trials. Some examples of that might be, does homework affect your mental well-being? So they randomized some of the school to get homework for a week and the half not to get homework for a week. And their outcomes were eclectic, to say the least, including mood. But they measured mood, quite innovatively, including they did a drama, scrapbooks. No, I should say that the scrapbooks would tell which group were randomized to no homework and which group were randomized to homework. And about 100 paces away, the no homework group was full of dark autumnal colors. Sorry, the no homework group was full of bright cotton wool and glitter. And literally opened it, glitter fell out. Whereas the homework group was dried leaves, twigs, brown colors predominantly. The competition is held in the award ceremony is held in Galway this May for this year's event, and it's on the website. And we encourage anyone who wishes for a lovely, fun day out. Please come down and hear the children reporting on their trials. You'll be amazed, and I guarantee you'll be surprised. And the website also has some lovely videos of the children talking about their trials and what they did. We also ran the People's Trial, which is a trial where we ask the public to come up with a clinical trial question and move with us through every step of the journey in how we design a trial for answering that question. And the question that we answered in People's Trial was, does reading a book in bed affect your sleep? Pleased to say that we involved over 3,000 people in the People's Trial. The reading trial that they answered within it, that was the question the public wanted to answer, we believe was the first plain language report that's concert compliant of a randomized trial, and that's published. So finally, looking at the time, in the training education, we host a lot of training events across the partner sites. So as a network, collectively, we're able to offer a lot of training. We've had over 30,000 people attend our training. We have hundreds of hours of really high quality training recorded on our website. There is a lot of learning available there from international leaders, some of whom are based in Ireland and some outside of Ireland, across different trials, methodology, topic areas. Well worth engaging in that. Please sign up for the newsletter, on which we announce all of our training activities and other opportunities. And I mentioned the online training repository. So that's me, just over 15 minutes. So thank you again, Seamus. Thank you, Claire. Thank you, Evelyn and Angela. And enjoy the rest of your afternoon.
For sending on that presentation under what must be very trying circumstances. We move straight on to our next speaker, who is Dr. David O'Reilly from Beaumont RCSI, who's going to talk to us about his PhD research experience. David.
Good morning, everyone. Thank you very much to the organisers for the invitation today and all their hard work in organising this event. I'm delighted to be here today to discuss my experience of conducting a PhD as a medical oncology trainee. So my talk is going to focus on two key areas. Firstly, a little bit about my work, which is mostly focused around liquid biopsy and non-small cell lung cancer. And then secondly, I'm going to focus more a little bit on the process and the pathway to reaching the goals of our research. So I'm very fortunate to have three outstanding mentors in Beaumont, in Professor Naidoo, Professor Hennessy and Dr. Toomey. And my PhD is broadly focused on improving the outcomes in non-small cell lung cancer through non-invasive diagnostics and novel biomarker discovery. And to reach this goal, we've designed a PhD program which spans the patient journey from the time of initial diagnosis, initial therapy, and their second-line therapy. And the first part of this is focused on improving patients' time to diagnosis and the accuracy of their diagnosis. And we've done this in the PLAN study. Professor Naidoo and multidisciplinary colleagues designed the PLAN study entitled Plasma Genomic Testing in Patients with Advanced Non-Small Cell Lung Cancer. In this study, our primary objective is to establish the feasibility of liquid biopsy for genomic diagnosis and targeted therapy selection. Patients are recruited at the time of radiological suspicion of advanced lung cancer from the Rapid Access Lung Cancer Clinic. And for this study, we enrolled patients in Beaumont, University Hospital Limerick, St. James's Hospital and the Beacon Hospital. Patients had their standard of care diagnostic tissue biopsy, which was complemented by the liquid biopsy as part of the study. The primary endpoint was the difference in days to genomic diagnosis between plasma and tissue genotyping. We commenced recruitment for this study in July of 2023 and completed in August of 2024. Just to give you a flavour of the results, we identified in our work that the introduction of liquid biopsy resulted in a 3-week reduction in time to genomic report. And we know that this time is so important for patients with advanced lung cancer. In particular, you can see that a significant proportion of patients, as illustrated by this graph, have reduced the time to diagnosis by 40 days or greater. So the next part of my work is focused on improving the experience of patients at the time of receiving first-line therapy for advanced disease. And in this translational study, the BRAND study, we're focused on this early first-line treatment part of a patient's journey. So this has gone slightly askew, but Professor Hennessy and colleagues in Beaumont have developed expertise in the use of exhaled breath condensate to detect ctDNA. In this initial experience, they identified that exhaled breath has enhanced sensitivity compared to plasma for the detection of EGFR EGFR mutations. And more recently, they've identified KRAS, PIK3CA, BRAF, and HER2 mutations in breath. So, given this local expertise, we developed the central hypothesis: reductions in ctDNA measured 3 to 6 weeks post-treatment commencement can be used to predict clinical benefit to treatment for patients with advanced non-small cell lung cancer receiving immunotherapy. And in this translational study, we recruited patients at the time of newly diagnosed advanced non-small cell lung cancer due to commence treatment with an immune checkpoint inhibitor plus or minus chemotherapy. Patients have pre-treatment breath and plasma samples and repeat samples at 3 and 6 weeks. We're recruiting patients across Beaumont Hospital, St. James's Hospital, and most recently Midlands Regional Hospital, Tullamore. To date, we've recruited 90 patients of a plan 108, so we're well underway, but we have a little bit more work to do. But to give you a flavour of some of the results, this is a 55-year-old male receiving first-line treatment with pembrolizumab and chemotherapy. We can see on his baseline imaging a right upper lobe tumour. His ctDNA kinetics are displayed in the middle. His EBC, or exhaled breath ctDNA, is in blue, and you can see a sharp reduction at 3 and 6 weeks. His plasma ctDNA kinetics demonstrate an initial rise followed by a clearance. He has thankfully had a partial response to treatment, which is happily ongoing at 15 months now. So in this patient, we've identified how EBC ctDNA has predicted benefit, a sustained benefit to treatment at just 3 weeks after commencement. So in the final part of my work, I'm focused on how we can define strategies to minimize the toxicity of combination treatment. And for this effort, we performed a systematic review and meta-analysis exploring the toxicities of immune checkpoint inhibitors and tyrosine kinase inhibitors. So all of these contribute towards the ultimate goal of the work, which is to improve the outcomes for patients with non-small cell lung cancer. So in the next part of my talk, I'm going to just briefly talk for a few minutes about what's involved, I suppose, in the research process and reaching this goal. Well, the first essential component is mentorship. As I've mentioned, I'm very grateful to have 3 outstanding mentors in Beaumont RCSI Cancer Centre. And through these mentors, I've gained the opportunity to collaborate with colleagues in biostatistics and molecular pathology, and very importantly, been able to run these studies with the support of the Cancer Clinical Trials Unit and Cancer Trials Ireland. Of course, they've also given me the opportunity to gain experience in grant writing, which is a challenging and somewhat arduous experience, but I think it's one that I've learned a lot from and will be very valuable to me in my career going forward. I've also gained opportunities to understand and appreciate the importance of patient and public involvement in research. And for my PhD program, we have a PPI advisory board who meet on a quarterly basis where we discuss the results to date and plan our future research studies. So with this mentorship, we have the opportunity to gain skills in clinical research like study setup, in laboratory work like PCR and NGS and genomics work, and of course in analysis like biostatistics. And as I said, I've had the opportunity to learn skills in meta-analysis and use some software programs. Ultimately then, the purpose of this mentorship and these skills is to develop scientific communications through presentations or publications. But then these all lead back to the ultimate goals or the outcome, which is to improve outcomes for our patients. So through our PLAN study, our liquid biopsy clinical trial, we hope that this will be an impetus to introduce liquid biopsy for all patients with newly diagnosed non-small cell lung cancer in Ireland. In our BRAND study, we hope that we can use exhaled breath in an adaptive clinical trial to guide treatment in the future following validation. And finally, we hope that our meta-analysis is informative for clinicians and clinical trial designers in defining strategies to minimize toxicity. So all of these ultimately contribute to the original goal that I started out with, which is to improve outcomes for our patients. And finally, to finish, I just wanted to reflect for a moment on the value of a PhD for clinicians. So first of all, it gives us an opportunity to innovate. There are lots of challenges along the way in research. And these skills in innovation and overcoming challenges are ones which I think are useful in clinical practice. We also experience lots of challenges in the context of a healthcare system where sometimes we don't have all the resources we need. In addition to this, we gain skills in critical thinking. A healthy skepticism towards a scientific problem is always helpful in trying to determine what's true from what's not. And I think equally in oncology clinical practice, where we face a highly complex patient population, these critical thinking skills can be helpful in diagnosis. And finally, research gives us the opportunity to take a bird's eye view of our healthcare system. Often, sometimes in clinical practice, we're so busy with the day-to-day, it's sometimes hard to have a moment to reflect. It gives us an idea where our field is going. It gives us expertise on how to navigate it and improve it. And finally, we develop the skills to deliver. So thank you very much to the patients and families for their contribution to these studies, to my mentors, as I've mentioned, Professor Naidu, Professor Hennessy and Dr. Toomey, a long list of collaborators in Ireland, and also, of course, to the funders, and once again to ISMO and CTI for the opportunity to speak here today. Maybe I'll stay. Yeah.
So thank you, David. That's a very fascinating talk. We do have a panel session coming up at the end where there'll be plenty of time for questions. But if there's one burning question for David right now.
They're all satisfied.
They're all satisfied. Great. That's great. Thanks very much, David. So I'd like to invite our next speaker, Miss Roisin O'Malley, I hope, who's going to talk about the role of radiation therapists and how part they can play in research for our patients. Thank you.
Thanks so much. Do I just click it along, is it? Yeah, so I'm going to talk about the expanding role of radiation therapists within radiation oncology research. So radiation therapy is sometimes one of the lesser known treatment modalities for cancer care, and yet 50% of cancer patients require radiation therapy at some point in their treatment journey. And 40% of cancer cures have radiation therapy as a component of their treatment. So what is it? So on the slide here at the bottom right, or the bottom left as you're looking, is a linear accelerator. So there's a electron gun there that shoots electrons, and they're accelerated and they hit a target made of tungsten, and that produces a photon beam then. And when photons reach the cells within the patient, they create double helix breaks. So basically DNA damage, which causes cell death. And I suppose cancer cells aren't as good at repairing themselves as healthy tissue cells, and that's how we get a therapeutic ratio, which is in favour. So it means that we're going to kill more cancer cells than healthy tissue. And the goal always with radiation therapy is to maximise dose to cancer cells and minimise dose to healthy tissue. So you can't have radiation therapy without radiation therapists. So there's 300 of us working in the public sector in Ireland, 753 core registered. So among private sectors are potentially working abroad, keeping their registration up. It's the only 4-year degree undergraduate in Ireland which focuses specifically on cancer treatment. What we are is we're healthcare professionals with the clinical responsibility for precise planning and administration of radiation therapy. And we're also the main point of contact for patients every day during their visits. We're highly trained and specialised in cancer care. We're detail orientated and we're focused on improving cancer outcomes. So it sounds like a good resource for cancer clinical trials. So how do you get us? So these are the 3 ways that we've gone about it in IROG, which I should have said is the Irish Research Radiation Oncology Group, and we linked all the radiation oncology clinical trials units in the country. So we've kind of a 3-prong approach here. So we're trying to inspire the next generation of RTs to participate in clinical trials. So that I'm talking about the student RTs coming through. We're also raising the profile of clinical trials among the working profession and advocating for career progression within the research RT role. So this is about a kind of program we ran last year in the St. Luke's network on introducing radiation therapy students to the clinical trials unit. So what we devised was a structured timetables for students. So while they're in getting their clinical placement hours, which they have to do a huge amount of clinical placement as part of the degree, we wanted them to have structured time where they came into us for a day. We do GCP training, explain them how we consent patients, data collection, basically a day in the life of a research RT. And we designed a survey to collect their feedback, and some really nice quotes here. And one student felt they gained a lot of knowledge from the session, one of their more educational mornings on placement. And another one, it was really good to see other options that are there for radiation therapists outside of purely treatment. So we took the results of the survey. There's a couple of more reports as well. And we went back to the student placement tutor, and we kind of discussed the results of the survey and our experience. And the result of that now is we have a formalised placement in the clinical trials units. So it's for all third and fourth year radiation therapy students, and they come in for a day and get to learn about clinical trials. And a lot of them hadn't heard about it. And the units often kind of separate within the hospital, and people are like, I don't know what they do up there. They're always at the photocopier or whatever it is. We're trying to reach out and be more known to just raise the profile of trials within the hospital. And so then this is about raising the profile of the clinical trials unit among our qualified RTs. So different ways to just reach out to the RTs working on the floor and in planning, and all the hospital staff. So lunch and learn events are really good for this. Conference presentations. So Jackie, one of our other research RTs, presented at the IIRT conference last year. And I know Karen and Erica have been speaking about research RTs at ESTRO previously, and days like today are just really useful. Also social media outputs. So IROG is working and CTI are working together to increase the number of clinical trials open around the country in radiation oncology networks. And we've had a really massive increase in our clinical trial accruals. So just putting that out on social media and getting kind of everyone excited about what's happening in radiation oncology research has been really important. And I suppose one of the outcomes of this is we had a vacancy come up in the Luke's network recently for clinical trials RT, and we got 10 applicants. So in a time of really severe staff shortages and everything, it was really kind of gratifying to see that there is such a high level of interest in this role. And then the third thing, career progression. Everyone's kind of almost sick of hearing about how everyone needs career progression, but it's just the truth. Otherwise, people will leave. So ESTRO have a definition of advanced practice RT. I'll have to read it from here. So they're looking at practitioners who work outside their standard operating procedure, demonstrate expert practice in a specialised area, and they work autonomously, taking on a leadership role in the development of RT services and research associated with their speciality. So really, if you break that down, you could be reading out kind of the job spec of a research RT. And there was a review of the radiation therapist profession carried out by the Department of Health last year. Last year. It was published in July, and fair play to SIFTU because they really canvassed for us to get this done. So one of the, I suppose, outcomes of the review was a recommendation was for advanced practice roles to be piloted in Ireland, and there was 3 areas that they were recommended. So advanced practice RT in a specific tumour site group, advanced practice RT for brachytherapy, and the third of the 3 is advanced practice RT for clinical trials. So again, that was really validating for us to hear, just that there was a recognition of the scope within the clinical trials unit for this kind of advanced practice role. So I suppose to finish up, what I'm kind of trying to say is there's only 300 RTs working in the public centres in Ireland, and IROG and CTI are working together all the time to increase the number of trials open in all these RT departments. So while we need our advanced practice roles and our specialised research RTs, we really want every radiation therapist in the country to be a research radiation therapist, in that everyone's aware of the clinical trials going on, involved in the development of these new clinical trials and implementing the findings of the research to continue to improve our cancer patient outcomes. And I know this was all focused on radiation therapists, but we definitely work as part of a really great team with our research nurses, our physicists, even the consultants, and none of the research is possible without the patients. So that's it. Thank you very much.
Roisin, that was fascinating. Just for you, a very good question. The advanced practice roles, do you have any idea whether those will be funded or not?
Oh yeah, they are going to be funded by Department of Health and the HSE, but just on a pilot basis. And so I think the results of that will have to go back off the pilot before, and I think it is a bit of a long road ahead of them. Yeah,
Great. And any other questions?
great.
Speeches. Thank you very much, Roisin.
Thank
And I'd now like to invite our next speaker, continuing the radiation theme, Dr. Jill Nicholson, who's going to talk to us about her research experience.
Hi there, so my name is Jill Nicholson. I'm a radiation oncologist. Thank you very much for having me here today. I look forward to more kind of joint ventures between us going forward in the future. So I'm currently the St. Luke's Institute of Cancer Research Fellow, and I work in a really good team alongside a radiation therapist research fellow and a physics research fellow. And we're so lucky in that kind of structure. It's enabled me so much to kind of develop my research. So today I'm going to talk about a little bit about just radiation oncology training, what it looks like, just because I'm sure you're not all as familiar with it as we are. And then about, in general, what our experience of engaging in research or engaging in trials is, and then a little bit about my own personal experience. Okay, so radiation oncology training is nationalised in Ireland. There's normally about 23. It's increasing to about 26 from next year, SPRs at any one time on the scheme. And we rotate around Cork, Galway and Dublin. Within Dublin, it's within the 3 St. Luke's centres. And as part of our scheme, we do get quite formal training on research at different time points. And I'm just going to explain a little bit about that. So as part of our scheme, we do 2 sets of exams. The first set of exams occur kind of early in second year. There are 4 theoretical exams. We do pharmacology, physics, cancer biology and radiobiology, and a statistics exam. And as part of that statistics module, we get some formal training in statistics, and a bit of research methodology is kind of mixed in with that too. And most people go across to the Christie to do a week-long course over there on this as well. So that's the first kind of bit of introduction you get to like kind of formal training and research and methodology at that point. Their second set of exams occur later in the scheme, normally at the end of 4th year, start of 5th year, and we sit a written exam and then do a clinical exam. And as part of the written exam, there are some evidence-based questions that form part of that. But we have this really good structured program called PBL, and it happens here in RCSI, and that occurs in second year. And it's a big time commitment for our second years. It's about 7 days in total over the course of the year. But it's a really, really valuable course that probably is the highlight of the scheme for a lot of people. So basically, it's a comprehensive course centred on practicing kind of evidence-based medicine. They get a lot of support from the NCCP, and the trainees work through devising a clinical question, going through a PICO method for searching, how to analyse research, how to stratify it all. And they basically don't just do this theoretically. They often work with the NCCP on a question that's being tiered up for one of their guidelines. And so they're being supported through the process. They're learning how to do this process, but actually, there's a valuable outcome that has some meaning at the end of it, and these get incorporated into the guidelines. So it's a really wonderful experience, and it's something that I think has been a positive development in our training. I'm a big fan of medical education. I'm doing a master's at the moment, so I could do a whole talk on this, but I won't. But I'm just going to briefly mention that, you can't have evidence-based medicine without evidence-based education. And there's lots of studies kind of around this area of how we integrate people and get them interested in research and how we keep them motivated. And when you look at all the research, there's kind of 2 overwhelming themes that always come out. And the first is you need to get people involved early, because it's too late as they drift later in their careers. There's other focuses. Whereas if you get people interested early in research and education and trials, they get much more engaged, and they kind of are able to overcome the barriers and feel much more confident kind of approaching it. And when you ask people, the perceived barriers are always the same. They're always, we don't have enough time for this. I don't have no idea how to get funding. And, who would I go to? Where would I need help? So, good mentorship programs are so important for this. And like I said, if we can get people at early stages, it really, really helps. And they can then see the path and they understand what more of an academic career looks like, and they can approach that. Okay, so we sent out a quick survey to our SPRs just to see kind of what their experience of trials were. And it was good. We had 100% exposure to clinical trials. So that's good. So all trainees are getting exposed in some shape or form to clinical trials. Most people felt they had, a reasonably moderate, 82% had moderate experience in assessing and reporting patient toxicity. So that's good. About half our trainees have completed baseline data forms. So that's good. In terms of the confidence in assessing and reporting toxicities, the mean score was about 7 out of 10. And then the confidence in assessing SAEs was a bit lower. It was about 5 out of 10. So there are areas that I suppose we can work on and make sure that people have support, when they're kind of carrying out these tasks. People did feel really well supported by the trials team. And I think you've met Roisin now. So we're very lucky that we have such a strong team kind of within our network that help. And I think the development of IROG and kind of unifying that across the country makes it a bit easier, because it means that as trainees, when you rotate around, you still at least know people. There's some familiar faces, there's some connections. So that really, really helps things. But as usual, they did report barriers for themselves engaging in trains. And it's the usual, I'm too busy and it's too much paperwork and I can't handle it and all that. But hopefully we can kind of help people to do that, because 82% of people did want to engage in trials in the future. One thing we looked at is since the inception of IROG, has that kind of increased the number of trials that trainees were registered on? And it has, from what we can see. So you can see that there's more trainees registered on kind of greater trials since the introduction of IROG, which is the orange line there. So that's good as well. So it obviously is having an effect. And especially with trainees, as you move around the country so much, and sometimes you're already been registered in a trial and you have to re-register, and then you're not, when a patient comes in, you haven't. So it's just kind of making that process a bit more streamlined. Okay, in terms of my experience. So I did get involved in research a little bit as I was going through my training, but I definitely had the same experience. I just felt I had no time. I never knew where to go. And, and I often developed a relationship with a mentor, but then you'd get moved to Cork and off you go and start again. And then next thing you're back in Galway and you have to start again. So that definitely does kind of have an effect. But one thing I did, as I was finishing my training and I was working on my CV, someone said to me, have you looked at how many trials you're registered on? And I said, no, what do you mean? They're like, ring the trials unit. So I think Roisin compiled a list for me. And I was like, oh, I've been registered as a sub-PI on loads of trials. Isn't that amazing? And sometimes, it's worth acknowledging that. And that's a lot of work involved. And you've learned a lot from that process. So I think that's something that everybody should try do. Just email your trials team and ask them what trials you're registered on. And it's a good section for your CV as well. But yeah, then as a fellow, I've kind of had a different experience. And it's just that same thing as every area of medicine. It's just having a bit more protected time makes such a difference. So like I mentioned, I'm currently the Slicker Fellow and we're funded by the Friends of St. Luke's and the Cancer Research Fund. And I work alongside a radiation therapist fellow and a physics fellow. And this is the first time we've had this kind of tri-modality fellowship. And it's been so wonderful because we've got 3 people in the same boat, but we're kind of in the same room and we can progress projects because we have the skill set from kind of each other, and it makes it much easier for just moving things forward. I've 75% research and 25% clinical, which is quite nice because that's quite a privilege at the moment. My research is actually mostly focused around breast cancer and looking at introducing artificial intelligence into the breast cancer pathway. And I'm registered as an MD candidate through Trinity for that. But I'm going to talk about something different today. So as part of the funding, one of the requirements was that we participate in an investigator-initiated trial. And I'm going to talk a little bit about that in a minute. But as I said, I feel that my fellowship has been a really protected experience and a really positive experience. And because I have that bit of extra time, I've been able to engage in other things as well. So I'm a trainee editor with the Clinical Oncology Journal in London, question writer with the RCRs, and I'm going abroad in the summer to do kind of an overseas observership as part of my fellowship. But to talk about the open trial. So as I said, as part of the fellowship, we were tasked with getting involved in an investigator-initiated trial. And this is such a wonderful opportunity to, answer a meaningful clinical question that we want to do and do it kind of on our own terms. And having a physicist and a radiation therapist and a radiation oncologist together on this just made this process kind of much more streamlined and so easy. And it was a lot of work, but we did it. So what we've done is we've set up a trial called Open. That's basically looking to test out a new type of radiotherapy mask. So I'm sure you're all aware when patients come for head and neck radiotherapy, they traditionally have a closed mask that's strapped in the shoulders. And some patients tolerate it okay. Some patients can find it extremely difficult and quite traumatizing. So there are kind of newer masks that are a bit more open. You can see them up there. And the question is always, though, are they safe? Can we actually use them? We've got some new tools in our belt now. So we've got something called surface guided technology, which is just picture loads of lights or lasers in the room that's just monitoring the surface and can tell you if a patient moves. And we were wondering if we use that alongside these open masks, can they be just as good as closed masks? And will they, change the face of radiotherapy for the future? So we set up a randomized trial. We've got 3 arms. 2 of the arms of an open mask. One is a 3-point open mask, so it's just on the neck, and one of them is closed, so there's a bit open in the neck and a bit open at the face. Because head and neck radiotherapy volumes often do come quite low, we were worried that the shorter mask wouldn't work, but actually with the surface guided, we're hoping that will kind of negate some of those concerns. And so our first question had to be, are they safe? But the next question was, does it actually make a difference? Are patients actually happier with them? So we're working on that trial now. So I'm going to talk about just my experience of kind of launching an IIT. So Professor Brennan, who's our director of research, just said, I want to use faceless masks. That was it. Off we went. So what we wanted to do was launch this new technology kind of under the safety of a clinical trial. So we knew by implementing it and embedding it into a trial, it just made us all a bit more confident, and it brought everybody along with us. There was a little bit of background work done because they had already used them for some extremely anxious patients, but it was in a slightly different setting. So we kind of took the information and the learnings from that. We needed to do a bit of a pilot trial to figure out how it would work, how we would develop surface guided. And Samantha, who's our radiation therapy fellow, did a huge amount of work in that and figuring out what mask we were going to use as well. But when you're starting this process, there's so much to think about. How do you think about stats? How are you going to manage your database? How are you going to randomize? And we were like, oh, we'll have a 2-to-1. They'll have twice as likely to get an open mass. That might help us recruit. But it's actually how are you actually going to randomize, And you're kind of what do other people do? And there's often envelopes on a, shelf somewhere, or a phone. And it's all those things you have to think of. But anyway, we've coded a little randomizer that somebody just needs to do. Roisin fills in on the computer and it gives you an arm. And it's all these little practical questions that you don't always think about. So how do you design the trial? How do we monitor it? What are our timelines going to be? PPI, which is so valuable. How do we register the trial? And then the other thing that we came up with was we wanted to make the trial as green as possible. Professor O'Reilly did help us a little bit. We asked him some questions about this. So our masks are compostable, and we have gone paperless for most of our work. So that's one way that we've tried to keep it as green as possible. We did get a patient involved as well. And again, that's another thing. You're like, we want to get a patient involved. What do you do? How do you go about that? And it was absolutely brilliant because the first thing he did was this trial is amazing. I really like this, blah, blah, blah. And then he said, but I wouldn't sign up to it. Like, what? And he's like, well, you haven't said that they're safe. You haven't said that enough in your leaflet. So you're like, oh, okay. It's helpful. So it was really, really helpful. And then at the back of your mind, you're doing all this work and you're like, is anyone actually going to sign up to this trial? So my experience is that there's so many people to engage. And it's really important that you interact with everybody and learn from everybody else. There are people who've done all aspects of this before, so you need to engage and get as much help and support as you go along. So there was lots and lots of people just, involved in the design of this trial. The other advice I have for people is this doesn't need to be a linear process. You don't need to go from an idea, okay, let's try to develop the trial design. Okay, what are we going to do with stats? How are we going to manage the database? How are we going to recruit people? You can kind of do it all at the same time and think about it really early on. So, people get obsessed with ethics, but actually one thing we learned to our detriment is that the ethics committee was actually okay. We got through that okay. It was the research management committee because obviously this was going to be a huge drain on resources, this trial. So we had to convince them, they could let us recruit as many patients as we wanted and as quickly as we wanted. So I think by engaging in those processes very early on, it makes it much easier to bring people along with you and much easier to address issues. And, for us, it was a very positive experience because we were able to do that. It's not always like that. I got ethical approval this week for a project I submitted in June 2023. So 19 months it took. So we were very lucky with this project that we were able to go through it quite quickly. So yeah, so the idea started kind of April to July 2023. We started exploring the feasibility around then. I formally started my fellowship in the August. And we wrote up the protocol. We had ethical approval by September. And we managed to get all the resources procured by the October. We did a training day in November. And we kind of ran away with ourselves and wanted to start straight away. But we had to delay a little bit for Christmas, just to allow the department to keep ticking over. And we got started in September. We're aiming for 200 patients. And we're currently heading towards 180, I think, last count. So we're really happy that that trial should hopefully be ready to present the data. And so far, it's been very positive. So overall, my experience of research is probably similar to a lot of trainees in that it is actually a really rewarding experience. There's lots to be gained. There's lots to learn from it. It makes the job much more social. You get to meet other people, you get to interact with other specialties and, other disciplines and universities. And that really kind of contributes to your experience of kind of your work as well. There are challenges, along the way. And sometimes those challenges can seem insurmountable. But if you kind of work with people and engage with people, it really does make a difference and it's totally worth it. So yeah, so thank you very much for listening to me.
Right. Any questions for Jill, or are we still on to the panel? And speeches. Thank you very much, Jill. So now we move on to our final speaker, Caitriona Duggan, who's an advanced nurse practitioner from Portiuncula, who's going to talk to us about nurse-led research. Thank you.
Okay. Hello, everyone, and thank you to Cancer Trials Ireland and to ISMO for giving me the opportunity to speak here today. So like Michael said, my name is Caitriona Duggan. I'm an advanced nurse practitioner in oncology in Portiuncula Hospital. I have 23 years clinical experience in oncology, 9 years as an advanced nurse practitioner, and 3 years, I'm in my third year of my PhD. So my talk today is about expanding nurse-led research, and I'm going to do that through describing my PhD journey and the contribution that I've made to the scientific world to date, and I suppose the opportunities for nurses going forward. So if we look at just specifically advanced practice in nursing, so one of the domains of the advanced nurse practitioners set out by NMBI is to be producing research. We know from systematic reviews looking at, so this was a review carried out in 2024. This was worldwide of nurses and the level of systematic reviews that have been published. And if we see here in Ireland, I know it's quite small, but less than 5. So to date, there's been very little interventional studies and systematic reviews where nurses are the PIs of this. So like I said, I'm 23 years working in clinical oncology. My master's was in integrative and humanistic psychotherapy, so it didn't really equip me with research skills to be a PI of a high-level interventional study. But everything changed for me in 2021. So a call went out from one of the academic leads in the University of Galway looking for a clinical lead to co-apply for the Cancer Nurse Research Award. To date in Ireland, this is the highest award solely for nurses, so €160,000 worth of a grant to nurses. At the time, that grant was for a 2-year process. So we had many meetings with the ICS, with our Sálta Hospital group and my local management about how we would use that 160,000. I wasn't inclined to do another master's. I already had one. I know many people go on to do numerous masters, but I had ambitions to do a PhD. So it took maybe about 6 months of meetings to see how we would run the two together. So basically, I was given technically what would be looked at in MSK or the likes as a fellowship. So I was released part-time from my post and backfilled, which is very lucky, and allowed me to conduct this PhD on a part-time basis. So my PhD is around vascular access devices for the delivery of systemic anti-cancer therapy. And if we look at all the SACT that's being delivered in the last number of years, 75% of them are delivered through the intravenous route. And we know from many studies that 1 in 4 PIVCs fail. So first-time insertion success is only at 75%. Many other complications such as phlebitis, extravasation, that's causes a cost to our health service, but also a huge cost to patients. So we knew we could do better. So our application was around conducting an RCT. And the RCT was around the use of ultrasound to improve first-time insertion success compared to our traditional methods of the touch and feel. This is my supervisor, Dr. Peter Carr from the University of Galway. So we were successful in that grant application. And this has been my PhD project plan to date. And as I said, I'm in year 3, starting year 4 in September. So the first was around the evidence synthesis. So we conducted a scoping review. We published our protocol in 2023 and our scoping review last year. So we conducted the largest scoping review in this area. Show you here. This is our scoping review. So 240 papers. We screened 5,076 papers and included in total 240 with 32 countries and 38 unique complications. So a huge amount of complications. we found 18 randomized control trials in that scoping review. That was published in Critical Reviews in Oncology and Hematology last year. Just to say, actually, and similar to what David, Roisin and Jill was saying about, I suppose, the components needed to conduct research and a research career, and looking at these two, a systematic review and I think a scoping review, so they all looked at things that have been discussed earlier. So these are three interrelated components that they've all identified as being essential for conducting this career. One of them being the personal motivation, and then really looking at both mentorship and organisational support. And I suppose those three things came together for me through the grant funding, through our Save the Hospital group, and again through my own motivation for the PhD. I'll just skip forward. So just when we look at this scoping review, like I said, it identified 18 randomised control trials. So this really showed us the need to conduct a systematic review and meta-analysis. So at that stage, we applied for a Cochrane title on the subject, and we were successful with this application, and our Cochrane review protocol was published in September of last year. And this is specifically around vascular access devices for prolonged intravenous therapy. And we identify this as any intravenous therapy given greater than 12 weeks, which is obviously the majority of cases. We have a huge group of co-authors, international co-authors involved in this Cochrane review, which we are conducting at the moment in the middle of data extraction. It was interesting to see Declan Devane's grant about core outcome sets, because it's a really difficult process at the moment extracting all that data, because we have no core outcome sets for complications. So they're all being reported differently. So that's a challenge at the moment. But we have vascular surgeons, we have experts in Cochrane methodology and PPI all involved in this review. And we hope to have that published in September of this year. One of the other real findings from our scoping review was the lack of papers around clinician factors related to complications for vascular access device. We found 7 papers out of our 240 that related to education, maintenance and management of complications. So we decided to conduct a survey, a European survey into clinician factors around complications related to vascular access devices and SACT. These are a number of our co-authors, and again, this is a really collaborative group all through Europe. So we have Professor Jonathan Moss, who led the largest interventional study, the CAVA trial around vascular access devices and SACT. We have a number of medical oncologists, nurses. We have members of the ISMO Scientific Board, EON Scientific Board. So we really hope to reach a really broad group when we were conducting this survey. And like I said, it's the largest survey conducted in this area. So we had 625 respondents, which is huge. And at the moment, we're analysing the survey results. So as part of the PhD, like I mentioned, we have a lot of European and international collaborators. We've also conducted 2 ENLIGHT studies. So this is our wider vascular access research team. We presented at INS last year in Boston, and as part of that, we were involved in a Flushing clinical trial, which will be published later this year. This is a meeting here on the right of our co-authors of our practice trial. And this was conducted at the World Congress of Vascular Access, which we presented our scoping review at last year. I've also been involved in writing chapters for Vessel Health and Preservation, 2nd edition, which was published last month. This is our clinical trial. We are currently waiting for ethical approval for this, and we hope to be recruiting our first patient in summer of this year. So the effectiveness of ultrasound for peripheral intravenous cannulation in oncology patients. So it was initially going to be conducted over 5. It's very aspirational. Maybe at the start of the PhD, it was going to be over 5 centres. Now it's a pilot RCT with 94 patients, just to within the limitations of the PhD. This is our beautiful ultrasound machine, which arrived a couple of months ago. So it's a 3D ultrasound machine. we are going to do a subset analysis of 10% of patients in our study, and we're going to look at the damage or potential damage to the subcutaneous tissue while the SACT is being administered. And we'll be able to get those images from that 3D machine. Going back to the scoping review, we found one paper that looked at that damage. It was conducted in Japan, and it was just on 11 patients. So this trial will be quite novel. And that's our trial. We also have a qualitative component on it, so we'll do focus groups with patients to see their perspective on it. I'll just go back one bit. We also have another paper just as regards the PPI. PPI has been embedded since the beginning, and they've been involved in, our PPI group has been involved in all aspects of our trials, in particular our survey and the construct of the survey. They were heavily involved in this. And I have it there in the slide. We have a methods paper. So the methods paper is around how we conducted a large European survey with PPI constructs, and that's received publication or received. It's going to be published in the next month. We received a positive report yesterday, so that's good. That's mine. I'd like to thank all my co-authors, and particularly my supervisor, Dr. Peter Carr, our Vascular Access Research team, and our Sale Hospital group, and of course the Irish Cancer Society, the NCCP, and the ONMSD for the funding of this grant. Thank you. I'll say to
Great. Okay, we're just going to do a panel now. Thanks, Caitriona. That's very interesting work. So now I'd just like to invite our speakers back down, and we're going to be kindly joined by Professor Seamus O'Reilly for a panel discussion. So if you could, so with all those questions you've been saving up very carefully, if you could pull them out, and I'll go to the audience maybe in a minute. But I had a question to start, or do you want to?
Very much. They were so inspiring stuff. And the range and diversity was just amazing, and the commitment. So thank you very much. It was really interesting today. As someone who I think every oncology day board in the country would have photographs of you if your trial is positive and with your ultrasound machine. So thank you very much. I thought one of the most interesting statistics was something Jill said, that 82% of people are interested, but the 73% are put off by the clinical work and paperwork. Yeah. And your final figure was 25% clinical, 75% research. So that was, so I think providing that structure really made a difference.
Yeah,
didn't it?
Definitely. I don't think it could have got the IIT off the ground without it. Because we have people in place, but nobody really has the time. And so we were able to recruit people and say, well, we'll help you as much as possible. We'll if you help us, we'll help you. We've got time to do things. We'll meet you whenever suits. We'll meet you remotely. We'll meet you in person. And that's what's brilliant, that we just had that flexibility available.
I'm going to just ask each of you, in terms of your peers, do you find that your experience has been beneficial to them? Do you get a sense of more of others following you in your roles?
Yeah, I think so. I think the fellowship that I'm doing at the moment, there was a fellow in place kind of 2 years before that. There was nobody for the 2 years in between. But this is the first time we've had that tri-modality, and it's made a real difference because it increases your output as well, because you're working together and helping each other out on your own individual projects. And then we've got a lot of collective projects. And I think the team in the radiation oncology world are sick of hearing about the three of us. We take every opportunity, Samantha's up there, to promote it. And I think hopefully there's people lining up to follow us. And I definitely think, as well as that, we've been able to help some of the kind of trainees or some of the radiation therapists or some of the other physicists get involved in projects and help them out as well. So that's good.
Can I say something, James? Yeah, I think in nursing as well, I think it would definitely be seen as, maybe aspirational or inspirational to be carrying out a PhD. But presently, I suppose our career structure is capped at advanced practice. So that incentive, I suppose, to go down the route of a PhD isn't necessarily there for a lot of staff. We had a meeting, a research meeting 2 months ago in Galway, and so many nursing staff got up afterwards and I want to do this, but how do I do it? what grants are available to me, what career structure is available to me. So that really impinges or restricts people from going forward.
Yeah, I think there's increasingly opportunities for trainees in Ireland to be engaged in research with, increasing amount of investigator-initiated trials, and that's so as I think people's lifestyle and landscape it changes. I think there'll be more people doing research in Ireland.
Yes, same. I'd say with the radiation therapists as well. Like I mentioned, that we had that job come up, and we got many more applicants than we would have kind of previous years. And I suppose, in radiation therapy, there's things like job flexibility is really limited, and career progression as well. And to be able to say, in research that there will be this advanced practice role coming in, or that there is chance for flexibility and kind of further learning and stuff, has been really positive for radiation therapists, I think, too.
Especially on the same points, really was for a long time in my training, and it is required for true ways to go across to teach your career pathway. That you think they've arrived at points now where Ireland can deliver
across the different disciplines, or is there more work to be done on that?
Yeah, I'm not sure, I suppose. Time will tell, perhaps, but I suppose I think there's certainly increasingly opportunities to be involved in research in Ireland of probably increasing like quality, and through that, the experience that people may have here may be similar to abroad. But I suppose, the people may still go abroad as well, I suspect.
I think, I agree. So I guess, people traditionally went abroad to gain a new skill, or, often because in other settings they might have more dedicated time towards research, which they didn't get. And I think there's definitely more opportunities for that here. There is more protected time and more protected funding coming available. There's more mentorship. We have amazing leaders here, and it's a pity to allow people to go away and just publish on behalf of other institutions. So I think that is changing. There's definitely some kind of attitudes and some,
Old people.
you might need to convince along the way.
Tread carefully here.
Yeah. But I think times are changing, and I think the thing is we have, amazing people here. We have amazing skill sets, and it's just that everybody works to such high clinical intensity all the time, and it's just kind of allowing people that bit of time and freedom to mentor people and help people do that, and hopefully.
I think it's very encouraging to see the examples here of how things can be done.
Mm-hmm.
Seamus, did you have other points?
I was just wondering, is there any questions in the...
Hi. Yeah, it's working. So hi, I'm Isabel, and I'm working on PPI in clinical trials. I was really happy to hear that you all mentioned PPI, and you have mentioned the benefits, but I would like to know also the challenges that you had to improve that interaction on from a researcher perspective.
I guess one of the things I'd love to see is more, you're like the patients are giving up so much time to participate in PPI, and I'd love to be able to, be able to, I suppose, pay people for their time when they're contributing so much. That so much of it is voluntary, and it's amazing, and it's brilliant that people and patients are so willing to give up that time. But I really do think that they're one of the only groups that we'd ask to do these kind of things for free. You know what I mean? Everyone else is working at this. So that's something I'd really like to see brought in with the IROG PPI group. And I suppose another thing sometimes is the people who participate in PPI are sometimes, we had patients come in recently to do a video to talk about their experience being on a trial. And one guy started talking. I was like, this is amazing. And he was like, yeah, I'm on the Sunday game. Like, do you know what I mean? He was better than the doctor. He's talking about trials and his points were so clear, whatever. But like, it's often the people who are really confident, quite highly educated, who take the time. And you want to make sure that the patient voice is the patients, all the patients are getting their voice across.
I think it's really important to have a really, really clear patient involvement plan, though, as well at the beginning, so that expectations are kind of set at the very start from both sides, and that avoids any kind of conflict or any issues going, in the future. So that's set out from the very, very beginning very clearly, down to how you contact people,
Yeah. I'd say on the PPI, you know, I think it's actually it's not simple, and it's actually there's a lot of complexity to it, and it actually requires probably like specific training to actually learn how to conduct PPI, and that's not something that like I don't think we're exposed to like in our sort of in clinical work. We might do research projects, but PPI is probably not a theme. So the RCSI have a course in PPI, which I found helpful because I actually didn't really have a good understanding of what it was until I did that. So I think the training.
I stole the mic. It's Evelyn here, CEO from Cancer Trials Ireland. And it's on that point because we have a patient consultants committee in Cancer Trials Ireland made up of people who've either been on trials or want to be on trials. So, and Emer is, I think Emer Mulvaney might be here, certainly online, is running that. So if you are in that, you know, you're asking that question, I have a study and I want patient engagement, come to us, come to that group. There's some really able people involved. Be careful what you wish for, and I can tell you, we're here to resource that. The second thing is, I really love the last question, Seamus, and to all of you. I always thought clinicians had to travel in order to get a job back home. That it's almost expected for the CV. I see nobody in the room wants to say this, so I'm going to ask it. And I think that's something that maybe, you know, if we're trying to encourage more of that training at home, that's potentially one of the things we need to look at in the country, is what we expect clinicians to have in terms of experience. But I challenge that a little bit around IMP trials, investigator medicinal products, because we really don't have enough of those happening in Ireland, especially at early phase. So in order to get that experience, I would argue you probably do have to travel abroad to do that. And will we ever get to the point where we don't? You know, so it's a statement and possibly a question for the panel.
So, Roisin?
And well done. Today was amazing, by the way. I've really enjoyed.
Thanks. That was a really nice set of presentations. Just to come back to Evelyn's point on this, I think it's going to be a balance. I don't think we can have everybody training in Ireland and have Ireland at the level it needs to be. We're a small country. So, but I think it is good to have opportunities for people within the country, if that's what they need from a personal or family perspective. And it might be that people do training in research in the country and then go abroad, versus they do all of it in increasingly excellent centres here. So I think it's a balance, but it is important for us to have the opportunities here as well, and to build our capacity in that area. In regards to the IMP, Evelyn, we've lots of IMP studies open in Ireland, not many investigator-initiated studies, but we have loads of industry studies coming through all of our cancer centres. So our trainees and our clinicians and our nursing staff and our radiation therapists are getting huge exposure to new drugs all of the time. And hopefully we can make those more complicated over time in terms of the types of agents with the, you know, newer treatments that are coming through. But I think a balance will be what I would suggest.
I think if I could add, I think we're cancer is going to increase by 70% in the professional lifetime of the young people in this room, and so we need more people to look after patients in our communities. And I think the more flexible and diverse more flexible the training programs are, and the more diverse the workforce are, the better that will be. I think the message that I got this morning from all of the talks today is that we need to provide structured, protected time and protected posts, like the breakthrough cancer posts, like the Irish Cancer Society supported posts, like the Friends of St. Luke's posts, as part of our healthcare delivery. I think that they are transformational, because it's not just influential on your careers, it trickles down to the careers of everybody listening here today. And I mean, you will be followed by other candidate PhD nurses, I suspect, because the people in the NCCP and the people in the Irish Cancer Society will look at the impact of the work you've done so far and say, if one person can do this, what about 10? What will 10 nurses do? You know, so I think that will be my feeling about it.
Can I jump in the head? Or I suppose I just want to make a comment, and it's actually what we have. But see here, NASPO is Test Trials Ireland and ISMO, it's a representative here. I was struck by how the studies are all, in a certain geographical location, but they could be very transferable all across the country. And while we have CTI and Senior ISMO People's Year, I think we really need to advocate for bursting down the barriers to sharing our research. If a trial is gone through an ethics committee in one part of the country, it should be accepted somewhere else around the country. IITs, especially that we develop, should be easy to open those in other centres in the country. We're a small country, we should be sharing our research. And I was struck by especially the Uppsala trial. So it just
I agree.
I suppose that's really what we are striving to do, Jack, to really increase that collaboration and that sense of support around the country. But yeah, absolutely a very valid point. I had just two quick, very general questions for the panel. One is, and it's actually it leads on a little bit from what Jack was raising there. Do you feel there's sufficient network among your peers in terms of supporting each other, bouncing ideas off each other? And secondly, in terms of lessons learned, if you could go back and advise yourselves at the start of your undertakings, and even Roisin at the start of your career moving towards the research unit, what would you actually advise yourself to do?
That's a really good question. And I guess in terms of the networking together, like with IROG, I suppose what we're doing, we have monthly operation meetings where everyone joins in from all the sites. And another thing we've done that's been, I think, really useful has been these kind of think-in, we call them. I think we should change the name, but it's, all the, say, consultants or anyone who has an interest in a topic, nurse specialists come together. And it's just a kind of informal meeting where any international trials they've heard of, and especially people coming back from abroad, often have these linkages with other sites, so international trials, but also IIT ideas. So we've done it for breast, and we've done it for CNS, and we were just saying now recently that we need to do another one for prostate. But following on from these thinkings, then people, again, time is the issue, but we get these great ideas for IITs and we're able to start moving forward with them. So that's one thing that's been really great, because I think, so like you're maybe in your own centre and you're thinking something would be a good idea here, but then to hear that that's a good idea nationally or whatever, that there'd be interest in all the sites. And we're really trying to roll out all our IITs now. Open is kind of limited to Luke's because it's about setup uncertainty, which is quite site specific, but all our other IITs, like we're no longer, if historically they were in Dublin, in Luke's, maybe in Beacon, and now we're looking to open them in every centre, I suppose.
I think as well, we've all mentioned it as well, and it kind of all comes back to the importance of just mentorship. And, in the radiation oncology community, we're quite small. And, I think there definitely does need to be kind of mentorship between senior trainees and junior trainees, and then between consultants and trainees as well. And the problem with any mentorship program is that ideally you'd want a mentor-mentee relationship to be an organic relationship, that people are working with someone who they get on with and, understands their style of work. And will support them through it. But because we all move around so much, because that kind of system will always leave a few people behind, that sometimes having a bit more of a structured or formal mentorship program can really help in getting some people, especially some people who might be a bit quieter, up off the ground and running and experience.
I think for me, personally, from going, so I went from advanced nurse practitioner, being in that role for so many years in clinical oncology, felt somewhat an expert in the role that I was in, and then going to the PhD journey, feeling like being an absolute novice, learning all the kind of different software programs. I think just going a little bit easier on myself, that, and just being aware that that's just a process to go through. But it was difficult to go from a place of feeling like an expert to a novice, and just acknowledging that.
Yeah.
And embracing it.
But yeah.
To have done that.
When you first start working in research, and I remember, like, I've been working as a clinical RT, I went to my first meeting, it was like for the CTU. I was like, what are they even saying? Like, all these acronyms. I was like, what is going on here? GCP, whatever, IMP. And just, to be easy on yourself and to give it a little bit of time, and then you'll start using them too.
I had another question actually for Seamus, if you don't mind. There's the in terms of clinical trials are very difficult or clinical research is very difficult to get up and running and requires a lot of support from a lot of people. And at the moment, our core funding for clinical trials unit is delivered through the HRB through a competitive process. And it can be difficult to get employment contracts for research nurses and for data managers through the university, or certainly long-term contracts. And I was wondering, do you think that the HSE could or should contribute more to funding core clinical trial or clinical research activity in our hospitals?
So this there's recognition that there's problems in terms of trial setup times. We're going to discuss some of that this afternoon, and also staffing. And so there's a National Clinical Trials Oversight Group that's been set up by the Department of Health, and it is made interim recommendations. And Simone Walsh, who's a nurse specialist in clinical trials, is on that group, and it has there's about 30 different representatives on the group in total. It's very inclusive, and it includes a patient advocate. So as part of that, they're looking at, first of all, the group's recommendations have made clinical trials as part of the programme for government in the current government. So it was discussed at the last cabinet meeting of the last government, so it's in this one. As part of that, they're going to do a part of that, Simone is doing a workforce exercise to map out research nurse staff throughout the country. And obviously the view then is looking at permanent, what kind of contracts that they're on, and ensuring that they have security of contracts, basically. And then looking at work, and then a second piece will be workforce planning as part of that, because if we're to reach the OECI targets that we want in our cancer centres, because we know that our cancer outcomes are going to be better. If that is the case, we need to increase the number of nurses. I also think we need career progression and career plans for the people involved in these organisations. I think that the one thing that the current HRB grant is up for renewal at the end. Will be re-engineered at the end of this year. And one of the things that has happened in the current iteration of the grant is the growth of trials without drugs. And so trials in radiation oncology, lifestyle trials like the McCarthy trial or like the LISA trial, where it's not just an IMP that you're doing as part of it. So I think it also speaks to a whole range of additional clinical research activity that's in the country that can also benefit patients. So if exercise was a drug, there would be a sign, that sign, the HC sign code would be replaced by Nike. So and that's disappointing for loads of, I won't go down that rabbit hole, but so I think that as part of, I think there's almost like, I think it's good in ways that there's two things coming together. One, this group is disbanding in July, so the recommendations will be made. So that's good because it forces decision making. And then the second thing is that there's a new grant system. So, and our hope is that these things together will lead to that the next grant cycle will address a lot of these things.
Thank you very much. I guess that if any more questions from the audience, are you all satisfied? No. Okay, so I'd like to thank each of our speakers today for a wonderful session, and we'll break for lunch now, and we'll be back at 2:00.